This video will share the workflow of a standard CHROME GuidedSMILE case. This case has a few highlights, including discussion on the smile, on the injection ports, and on the specific photographs for CHROME GuidedSMILE. As with almost all dentate cases, this is how the records are sent. Bottom left is a CBCT scan. Bottom right is either digital impressions, like this case, or standard impressions or casts or articulated models. It's nice to have a CR bite, but a centric bite is what we mostly receive, and that's fine. We can open the case from there. And the photographs on the top right, which are always retracted in occlusion. We always want to see how the teeth are coming together so that when we articulate the case, we can confirm that the bite is correct. And then the patient photos, which is full face, full smile. In this case, also repose, and then a profile if it's necessary as far as lip support, overjet, class 2, class 3, that type of thing. So these are the general records for a CHROME case. In this particular case, this patient has a reverse smile, and that is an indication of a closed bite. I mean, there can indicate other things, of course, but generally a closed bite. Often you can see some soreness and redness around the commissures. But this is an indication, and it helps us decide with you, the doctor, how much to open the bite. And so we ask for a repose picture so we can have a discussion, so that we can analyze the records in a little bit different way maybe than other cases. So in the profile picture, you can also see the reverse smile and perhaps the need for some lip support, but that may be a judgment call based on the patient needs and wishes and the doctor. So these are some nice photos for us to help evaluate. And then, of course, an exaggerated smile is nice, or just a normal smile. In this case, the patient has a really tough time showing any maxillary teeth, so we asked him to do an exaggerated smile so we can really tell how long the teeth should be and help us determine how much to open the case. So with these photographs, we can really do a nice analysis. And then these photographs are really nice too. And just some further analysis of these pictures, the doctor has the f-stop set pretty high, which is nice, probably an f20 or higher. And what that means is that we can see the surface of the teeth very nicely on the anterior and the posterior, so we have a nice depth of field. So a nicer high f-stop is what does that. Every camera is a little different, but as far as depth of field, f-stop is the way to go. So with these records, we will articulate, digitize, bring the files into Blue Sky, plan the case and prepare the case, and then we will host an online meeting where we'll meet the doctor live online and go through the case. When the doctor joins, all the implants will be placed. The proposal for tooth position, the bite, the opening, the case is really set up for hopefully a 30-minute meeting to go through each implant site, manipulate the implant, put it in just the right position, and generally those meetings, almost always those meetings go one time and then we go forward with the case. Sometimes there is some changes perhaps in the teeth, the tooth position, that type of thing, or perhaps a change in bone reduction leveling where we may have to go back and do a new setup and have a subsequent online meeting. But for the most part, it's one meeting and then we move on. And once the meeting is finished, the case is fabricated, and that takes 10 days. So we have a 5-day, 10-day rule. We take 5 days to work up the case, to get it ready for the online meeting, and then 10 days to fabricate after that online meeting. So on day 10, we ship the case, arrives to your office. We ask doctors to go through the case, make sure everything looks correct, make sure the guided kit fits the osteotomy guide, make sure the pins are tried in and that the fixation base is assembled to the bone model, so just to get an understanding of exactly how much bone reduction and kind of set the tone for the day of surgery. So day of surgery, this is again, it's a pretty standard chrome case. It's going to be an FP3 type prosthetic. And step one is always try in the pin guide and make sure that it fits on the teeth, that there's no rock, that it seats solidly. The pin guide has windows to make sure that it's seating on the teeth. And if there's any rock at all, you'd want to adjust. But these pin guides fit very snugly. There should rarely be a rock on a pin guide. And then the pin guide is removed and the labial reflection is performed. Not very much lingual, if at all. Generally no lingual reflection until after the pin guide is in. So reflect up beyond the pin guide, up beyond the fixation base. And then they are assembled. The fixation base, the metal, and the pin guide, the plastic, are assembled with the chrome locks. They're inserted and they are held firmly in place while the sites are drilled. So this would be a situation where the assistant and the doctor would hold this pin guide firm. It can't move. It can't rock. And if there aren't many teeth remaining, then it's partially tissue supported. It's very important that it's held firm, because if this moves and there's one pin in the correct position and the next pin is not in the correct position, then the fixation base is in the wrong position, and subsequently everything is in the wrong position. So hold firm. Drill a site, put a pin in, drill a site, put a pin, site, pin, etc. until the fixation base is in. And then the pin guide is removed, and what's remaining is the fixation base and, of course, the teeth and bone. Now, unlike all other guides on the market, especially, of course, plastic guides, that's really all there is on the market is plastic guides. But unlike other guides, ours is floating. This is called floating guide technology. So there is a gap between our guide and the bone. It never contacts bone. The only thing that contacts bone is the pins. As you can see here in the planning software, this is the reduced bone model, and the fixation base is completely pin supported. So this relies on trajectories of pins to hold the metal in place, hold it in balance during the entire procedure. And because of this small footprint, you don't have to worry about reducing bone to make your guide sit. You don't have to worry about leveling bone or just adjusting until it kind of balances in place. It just doesn't exist. There is no path of insertion issue. This goes beyond the labials of the teeth and is completely delivered by the pin guide, as you can see here. So the pin guide sits on teeth and delivers the fixation base. And once the fixation base is in, then the next step is to level the bone, at least in this chrome type. We also have chrome natural, where these teeth would be extracted and you deliver an FP1. We've developed that over the past couple of years, which is really nice, because leveling the bone is not always the best option for a particular patient with an FP3. So deliver an FP1. But in this case, and in a lot of the cases, you'll reduce the bone down to the level of the fixation base. So here's just an example of what we do. So the fixation base is the leveling plane. And use whatever tool. This is a very aggressive burr, but doctors use rangiers, piezo, surgical saws. Level it down until you see the bone is reduced to this plane. And with a gloved finger, you can transition your finger from the metal to the bone, back and forth, just to make sure there's a smooth transition, and that there's no lip or catch or sharp edges. A lot of doctors will also adjust the labial and the lingual of this ledge so that there's no sharp angles behind the tissue. That's another important tip, especially if you have sharp angles, because that will cut the tissue. It'll be a source of irritation and perhaps even pain or worse as the patient recovers. In this case, the doctor spun some blood. And the next step is to drill the osteotomies and place the implants. This is a BioHorizon surgical guide, and on BioHorizon we use OEM sleeves. They have some very nice machining on their tools, and doctors really prefer to have their sleeves placed. So it costs a little bit more, another $20 per sleeve, but they are placed, and the doctor will simply follow the guidelines of the toolkit, and drill the osteotomies and then place the implants. And with Nobel BioCare, I believe the implants are also placed through the guide, which is nice, which means it's a fully guided kit. Some kits are partially guided where you're only managing the drills with the guided kit and then manually placing the implants. That's a partially guided kit. So once we're going to skip ahead a little bit here on this case, but once the implants are in, once the temp cylinders, the MUA abutments are placed and the temp cylinders are placed, and then the prosthetic is simply sleeved over the temporary cylinders, like so. And you can see a lot more detail on that in other videos of rotating the implant for indexing, and then seating the MUA abutments according to the carrier guide notches. There are many indicators on there to give the doctor the important tools and information to index the implants, because you want the temporary cylinders to be straight and hopefully parallel. Not all are parallel, of course, because it's not always possible with the bone. So the prosthetic is seated, and then it is luted in place. As you can see here, see, this is actually the rapid appliance, the dual pickup, and this is the patient's prosthetic, long-term prosthetic. Looks like this was not adjusted at all, which is nice, which means the doctor really did a nice job with placing and indexing the implants. And then the next step is to just simply backfill this to connect the prosthetic to the temporary cylinders. Of course, don't forget to put the block-out gaskets in and the blue plugs. And again, you can see that in a lot of detail in many of our videos, most of our videos. Then once you've picked up both the rapid appliance and you've picked up the prosthetic, then CHROME can be removed. We're developing a system now for an extraoral conversion, where you'll just pick up the rapid appliance and you'll do the prosthetic conversion outside the mouth. Developing that now. It's very exciting. But once you've picked up both, remove the prosthetic, go through the normal procedures of suturing, putting comfort caps in, and finishing that. This prosthetic has been removed. As you can see, it's been picked up here. This is the surgery mat. At the end of the surgery mat sits on the counter, and the doctor places all the temp cylinders here, places all the appropriate respective MUA abutments here and implants here. And it's just a wonderful guide to organizing the parts and the implants prior to surgery. And then, of course, the surgery mat, which is on the wall. This has all the indications about the surgery, which tool to use, as here for BioHorizon, tells the doctor to extract number 7, and then all the cross sections of the implants and which spoon to use on which implants. A very helpful tool. So the case is picked up. This is what it looks like, occlusal intaglio. After it's been processed, probably need to fill the hole here. And so this will be adjusted until it's smooth. And then the occlusion will be refined once it's seated. Right, nice work. Now this picture doesn't really do it justice. I think a little bit of flash really showed these interproximals not looking too good. In the mouth they looked better, but I think that there was probably a little bit too much material and glaze added after. But notice one thing, these injection ports, they're not really necessary. I know some doctors like to use them because they want to put the patient in occlusion when they're picking up, and that makes sense. It's nice to have occlusion refined or at least balanced before you send the patient home. However, with CHROME, all of our cases are articulated on conventional articulators. We take the pre-op bite into account. The bite should be on, very, very close to being on. And if the prosthetic is manipulated or moved or floated in at all during surgery to get occlusion right, then occlusion might be wrong, because often patients wake up and they hit in the posterior first. And that is not always a bite issue. That is often a muscular issue. It's often a condylar issue from trauma and from being open for 2, 3, or 4 hours. And so if a patient hits early in the posterior, floating the prosthetic and tipping the anterior down is not really the right thing to do. The better thing to do is do a minor equilibration and have the patient come back in a day or two, and the patient will naturally go back into the proper bite more often than not. So just a little caution about using these ports for that reason. And you also have to clean the ports up. I mean, this is obviously the most aesthetic part of the prosthetic. And you don't have to inject when the patient's closed. You can pick up from the occlusal while the patient's open because occlusion has already been taken into account. However, that's our recommendation. Doctors use different techniques for seating the prosthetic. So the sutures, and then the case is seated, and you can see it does look nicer here in the mouth. And a very nice result. Doctor did a really, really nice job here on this case. And the patient is equilibrated and dismissed. And thank you very much for watching another CHROME Guided Smile surgery.